Uh, Hi, everyone. We'll wait maybe another minute or two for let people to come in, and then we'll begin. So I want to welcome everyone to the Citywide Psychiatry Grand Rounds. Hopefully everyone enjoyed a great summer, and thank you for coming back to our monthly gathering. And it's a pleasure to see everyone here today. I'm Raj Rathasingham, the CPD Director, and we have a wonderful Grand Rounds today, and I'm very excited to co-host with Sinai Health Systems the September Grand Rounds. Um, Before we begin, if you wouldn't mind, I'm going to read the land acknowledgement. I would like to begin with an acknowledgement of the land on which we work, study, and live. I want you to take a moment to situate yourself and think about the land under and around you. We recognize that many Indigenous nations have long-standing relationships with the territories upon which the sites of the Department of Psychiatry are located and that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional treaties of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat people. Today, this land is home to so many diverse First Nations, Inuit, Métis people, and we're grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississauga and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. This is the wonderful presentation that we have, and I will let Bob do the formal introduction of Deanna. Evaluation link will be sent to your attendees after the presentation. Your feedback is always appreciated as we continue to improve this event. The next Citywide Psychiatric Grand Rounds on October 31st, and it's CAMH is co-hosting, so I hope you'll be joining us then. Okay, now I'm going to pass it on to Dr. Mauder, the PIC of Mount Sinai, to do the official Sinai welcome and introduce Deanna.
Thank you, Raj. It's my great pleasure to introduce Deanna Chaukos to anyone who's joining in who does not know Deanna yet. Deanna is a consultation liaison psychiatrist at Mount Sinai and our physician lead for medical psychiatry. At the University of Toronto, she is an assistant professor. She is the associate program director for the University of Toronto Psychiatry Residency and theme lead for professional standards in the MD program. Deanna's research uses an adaptive expertise theoretical framework to understand how we effectively prepare medical learners for uncertain practice, including how to approach ambiguity in the clinical care of complex patients. She has extensive experience supporting curriculum development with a focus on integration of intrinsic CanMed's roles. I'm greatly looking forward to what Deanna is going to teach us today. Over to you, Deanna.
Thank you so much, Bob. I really appreciate it. And thank you so much, Raj and the department for hosting this talk today. We were just saying that it's apt to start with an education presentation in September. So I am just going to share my slides. Everyone can see that okay? I'll assume you
Yes,
can.
yes.
Great, thank you. So today I'm honored to be here to talk about rethinking interdisciplinary education, the role for adaptive expertise toward knowledge building communities. We'll unpack all of that. Before I begin, I do want to thank a few people. Maria Myelopoulos is a professor and scientist at the Wilson Center. She's my mentor and also collaborator on this work. And Sandalia Ginas is a PhD anthropologist and was the research coordinator on many of the projects that I'll share with you today. And I'll introduce the more distributed research team later on in the presentation. So these are our learning objectives. By the end of this presentation, I hope that you'll be able to describe adaptive expertise in health professions education, why it's essential for the care of complex populations, to identify learning mechanisms that can support patient-centered integrated care for patients with complexity, and to identify characteristics of a knowledge-building community utilizing the HIV Psychiatry ECHO as an example. So first, we'll talk about what adaptive expertise is, why it's important, the answer is complexity, and how we cultivate it in psychiatry at the individual level, meaning at the dyad of a teacher and a learner, and also at a team-based level in clinical contexts. And then we'll talk about how we can cultivate these learning mechanisms in a community of practice toward something called a knowledge-building community. I hope by the end of today, you'll walk away knowing that the role of medical education is to produce future experts. At the end of training, you are not meant to be an expert, but hopefully we are imbuing the skills and abilities for future expertise in all of our learners. Adaptive expertise is a theoretical framework in health professions education that describes how experts work. And so there are some learning mechanisms and characteristics of experts that I'll talk about now. The first is flexibility in patient care. An expert can apply an efficient solution to a simple problem, whether it's application of guidelines, best practices, and they can also adapt knowledge to solve new problems, being able to know the difference. Experts can navigate ambiguity. The way they do this is through innovation. They can adapt and create new knowledge to solve new problems. So experts find themselves problem defining and problem solving simultaneously. Experts engage in continuous learning, lifelong learning, and integration. When we say integration, what we mean is experts are able to integrate conceptual knowledge, the why, with procedural knowledge, the what. And they can apply this deep conceptual understanding. It allows for individuals to be able to move beyond the basics when a familiar procedure fails. Experts are able to use that conceptual understanding to create an innovative response to a problem that may not yet have a solution. So as I mentioned, adaptive expertise describes how experts operate. Though those learning mechanisms and characteristics of experts may not seem surprising to many of you, experts in your field in the audience today, it's important to realize that experts don't necessarily know how they operate and are not necessarily able to describe it for learners. And so this area of health professions medical education helps break down how experts operate so that as medical educators, we can work backwards. And this allows us to deliberately cultivate adaptive expert abilities in training, recognizing that expertise is a muscle that you flex. It's not a trait that you have or don't have. And as I mentioned, the purpose of health professions education is to create future experts. We shouldn't leave this up to chance. I think that this should be something we deliberately do in our training programs. Atul Gawande is quoted here as saying, "The volume and complexity of what we know has exceeded our individual ability to deliver its benefits correctly, safely, or reliably." I think speaking to the idea that expertise can happen at a team-based level as well. let's talk a little bit about what medical complexity is. Medical complexity originates from interactions between patients and contextual factors, such as the health system and socioeconomic status, psychiatric illness, medical illness, the intersection of these. And it's important to recognize that this term, medical complexity, may indicate more about a healthcare system and the limitations of our healthcare system than about the individual patient before you, because I think we can all recognize that our healthcare system is reliant on standardization and in many contexts may be better suited to address acute care visits or single disease models. We know that patients with complexity present with multimorbidity, oftentimes multiple psychiatric and medical illnesses, ACE and trauma histories, and other social and structural barriers to health. In the health professions literature, complexity has been conceptualized for teaching. For example, it can be conceptualized as a network of individual factors that interact to produce new properties different than the sum of its parts, and that this interconnectedness is dynamic. It makes it more challenging to predict outcomes compared to non-complex systems. And this is one way of understanding why it's more likely for patients with complexity to present with clinical ambiguity. Perhaps you're starting to see how adaptive expertise can be part of the solution here. So medical education has to confront this challenge of developing competent professionals prepared for future uncertainty, prepared to become future experts. Probably most of us in the audience didn't go into our training expecting a once-in-a-century pandemic to mark our medical careers. And yet here we are. So I think we need to help our learners move beyond evidence-based medicine and teach them to ask questions like, does this pathway or does this best practice apply to my patient and why not? And not just that it doesn't, but to be able to act as a physician amidst that uncertainty or as a healthcare worker amidst that uncertainty. And there are lots of wonderful examples of how to do this and how to integrate an adaptive expertise theoretical framework. Sasha Agarwal has done case-based learning in the psychiatry residency and published on that. And there are many other examples of how we've tried to integrate these principles into our residency program. And I think we need to acknowledge that traditional and reductionist approaches to education fail to account for the main features of complexity, namely when there is no one right answer. And yet we need to prepare our learners to be able to act despite that ambiguity. As Bob mentioned, I'm a CL psychiatrist, and as a CL psychiatrist involved in HIV psychiatry, I think adaptive expertise has always resonated with me. And this is why we've pursued the research that I'm going to share with you today in the HIV sector. Patients with HIV present with complexity, and they often fall through the cracks in our system due to structural exclusion. People living with HIV with psychiatric illness and substance use problems require care across hospital and community settings, often tertiary or quaternary infectious disease specialists, family doctors, psychiatrists, and numerous psychosocial supports that exist in the community. And fragmentation here is prevalent due to difficult to coordinate care and the fact that we often work in silos in medicine. So the HIV sector in Toronto, we're luckier than most. The resources do exist. However, fragmentation and barriers to patient-centered care means still that many do not have access. I'll share a little bit about our research methods. We have pursued qualitative research methods, essentially thematic analysis of interviews, focus groups, ethnographic observation in diverse educational settings, including clinical settings locally at Mount Sinai Hospital at the Clinic for HIV-related Concerns. And the purpose of our work has been to explore how an adaptive expertise conceptual framework can help solve educational and clinical dilemmas posed by complexity in the HIV sector, and I think beyond. The aim of our work has been to identify learning mechanisms that can support expert work toward patient-centered and integrated care. And I think what is unique about our work is that we are looking across different roles, clinical and other healthcare worker roles across contexts in the community and also in hospital. And with respect to roles, the community roles are both clinical and non-clinical roles, community case workers, peer workers, knowing that these roles are essential for integrated care. I've included Stella Ng's paper here as a resource because inherent in this work, we're talking about adaptive expertise today, but inherent in this work is a critically reflexive practice with recognition for the fact that most medical education efforts do not include healthcare workers from outside of professional pathways. And we know this about interprofessional efforts as well. They typically happen in clinical settings. And this work really does try to transcend community and hospital with recognition for the fact that a lot of mental health care is happening in community, and in the HIV sector, that's for sure the case. So let me share with you what we found from our work. In psychiatry, these key learning mechanisms have been shown to support adaptive expert work, supported by numerous of our studies. The first is fostering epistemic humility. Epistemic humility is awareness of the bounds of one's knowledge or what is knowable in a given situation. A stance of epistemic humility allows for inviting uncertainty. At the beginning of this path, we used to talk about tolerating uncertainty. And over the years, we've changed how we talk about this to inviting uncertainty, because the passion for which one can invite uncertainty really does speak to what happens next. Inviting uncertainty is the first step of a process. It's not the last. And so we know that those who invite uncertainty are more likely to facilitate continuous learning. And in clinical care context, that typically means it leads to collaboration. When I say collaboration, what I mean is engagement and perspective exchange, not simply task sharing. And when we engage in perspective exchange, to truly learn another person's work, their lens of seeing the work, including the personal lens, the lens of the patient, the lens of the peer worker, engaging perspective exchange allows for us to expand our scope, to lead to improved innovation and improvisation, and what we have called collaborative reformulation, being able to integrate those diverse perspectives into a new understanding of the problem. And when we do this, it leads to integration. So when healthcare workers invite uncertainty, they engage in perspective exchange. This facilitates integration of diverse knowledge types. And as I mentioned at the beginning, we know that healthcare workers who can integrate knowledge, the why with the what, that is a marker of expert work. Part of what we've worked on is characterizing how does this happen in psychiatry? And so what we've learned from our work in psychiatry is that integration really looks at integrating knowledge across different roles, including the patient perspective, the clinical perspective, community caseworker perspective, and that this promotes patient-centered care. These learning mechanisms can break down silos that exist between roles, support collaboration, perspective exchange, not just task sharing, and more effectively address the multiple social and medical concerns that patients with complexity come to care with. And this leads to collaborative reformulation, as I mentioned. This is another way of looking at these learning mechanisms. And part of what I wanted to illustrate here is that though they are each unique entities, they do overlap, and one often leads to the other. And this is how we see evidence of adaptive expertise in psychiatry, in HIV psychiatry, and in the HIV sector. There are evidence-based ways to cultivate epistemic humility, and so I wanted to include some of these here as a resource for all of us. Inviting uncertainty. And when we do this, we need to make it explicit, especially when you're working with learners. Say it aloud and say it without self-deprecation. When we say, I don't know in medicine, it can feel almost like a shameful admission. And there's no wonder for why that is. I think the culture of medicine privileges knowing over not knowing because knowing often facilitates an easy way forward. I think what we want to do is to be able to invite uncertainty and recognize that's the first step. It's not the last one. We can use uncertainty to create what's called a time for telling. So Schwartz has described a time for telling as essentially creating an appetite for learning. That when a learner becomes aware of a deficit in their knowledge, they are primed for learning. That is when the teacher should teach, because that is when the learner will be most likely to absorb that knowledge. Related to this is the concept of productive struggle as an opportunity for learning. I think we know that grappling with a problem helps optimize learning. And similar to number one, we should put words to the experience of productive struggle. Discomfort doesn't have to mean that you're going it alone. As teachers, we can put words to the grappling that's happening. We can speak about our own productive struggle in our careers and normalize that this is an important process to happen, especially when you're working with patients with complexity. And so I think how we talk about failure is really important. How we talk about our own difficulty navigating ambiguity in practice, making the implicit explicit. And then the fourth strategy is pragmatic empiricism. So pragmatic empiricism is when teachers and learners speculate together on possible ways forward, the next safe step in a patient care situation. So teachers and learners might say, well, there's ambiguity in this situation. Our differential diagnosis is this. If this diagnosis is correct and we try this treatment, then what would we expect? And how would we expect things to change if it was in fact a different diagnosis? This allows for learners to see how there can be a way forward amidst ambiguity and amidst uncertainty. As I mentioned, a really important part of this is I don't know marks the beginning of the process, not the end of one. Uncertainty in medicine has been criticized as a way of relinquishing responsibility when things get difficult. And I think if inviting uncertainty is the first step, not the last, that's actually not the case. It's actually quite efficacy generating, and it leads to our next learning mechanism, which is perspective exchange. So perspective exchange is also a learned and modeled behavior. For medical trainees, they tell us that when they see their staff calling caseworkers and community workers, getting collateral, not just clinical information, but relevant, diverse kinds of knowledge, that this helps demonstrate a way for navigating ambiguity in practice, and that perspective exchange is part of our professional identity. For community workers, when MDs engaged them as part of the circle of care, they were much more likely to attend patient appointments, to follow up on medication adherence and expand their scope within that realm, and to advocate for their clients to consider psychiatric help. Essential for perspective exchange to happen is psychological safety. When we talk about psychological safety and adaptive expertise, we're talking about psychological safety for risk-taking, psychological safety for productive struggle, like we just talked about. And when there is a traditional power hierarchy at play, epistemic humility is essential for creating psychological safety. When the provider with the traditional with traditional power in a relationship models epistemic humility, invites uncertainty, and seeks perspectives, that really does create psychological safety for others to share their perspective. For community workers, we heard again and again that perspective exchange was perceived as a risk. We heard this from trainees as well. And it was perceived as a risk that really had significant positive consequences when they did it in contexts where there was psychological safety. That after that experience, it increased their future willingness to share their expertise with others. It actually also helped them become more aware of the expertise and the important role that they brought to a circle of care. When we invite uncertainty, engage in perspective exchange, we know that this is more likely to lead to integration, that collaborative reformulation where a new understanding of the problem, integrating different kinds of knowledge, allows for forward-looking and problem-solving. When integration happened, it had benefits for community workers, for psychiatrists, for patients. We'll go through some of these benefits now. For community workers, this kind of integration improved awareness of team-based care, how they could navigate a hospital system effectively to help in the care of complex patients, and also to recognize that they could do it as part of a team. They didn't have to work alone. And it led to improved awareness of mental illness and possibility for treatment. One thing I would say that has been most humbling for me as part of this work is the recognition that many of our community worker colleagues don't necessarily think of psychiatry as a place to get help. And I think one of the things that happens when you can create psychologically safe places for perspective exchange is an opportunity to challenge anti-psychiatry viewpoints or even an abolition stance towards psychiatry. And it was really humbling to me every time that this happened, and there was an opportunity to truly engage in perspective exchange and see idea diversity at play. For psychiatrists, we also saw benefits of integration, that there was an improved awareness and an increased taking of responsibility for their role in anti-oppression work, and to explicitly recognize structural exclusion for the patients that they were seeing clinically. In many ways, it was modeled by the community workers and the perspective exchange that they saw, and they were able to adopt it and expand their scope. We also saw improved recruitment of distributed and informal teams toward integrated patient-centered care. Because, of course, in the HIV sector and in many CL adjacent type sectors and in many aspects of psychiatry, there is not necessarily an integrated care team that's established. These are informal teams across hospital and community, and the psychiatrist has the ability to initiate recruitment of these teams. And for patients who received care from these care dyads described their care as less stigmatizing than it had been in the past, more accessible, holistic, and coordinated. And they attributed this to integration, to the interchangeability between the community worker and the psychiatrist, that they could talk to their psychiatrist about their housing application and know that the community worker would get an update because they work together. And similarly, ask questions of the community worker about their medications, with recognition that they would probably come back to them after having spoken to the psychiatrist. And the other thing that came through is that when these informal teams occurred, the accessible stance of community organizations, which was seen as less intimidating, less formal, helped build trust in the medical context as well. There are evidence-based learning mechanisms to support integration specifically. We talked about the first, that knowledge is best learned when procedural knowledge, the what, is tied to conceptual knowledge, the why. When we understand why we do something, we're able to go back to first principles to innovate when necessary. And then the second learning mechanism to support integration is meaningful variation. One way that we can help learners learn from volume is by helping them to learn meaningful variation between cases. So a strategy to do that are what-if questions. So I've just seen a person with HIV and a history of a substance use disorder, and the resident I'm working with has diagnosed a major depressive episode and proposed treatment. I might ask, how would you approach this case differently if you knew that this person was pregnant? Or how would you approach this case differently if you knew that they were unhoused? And these types of what-if questions help us to scaffold information and knowledge towards expertise. Okay, so I hope I've explored a little bit how these learning mechanisms happen in psychiatry, how they're related to each other, and how they facilitate each other. Next, I want to talk a little bit about how we've taken what we learned at the teacher-learner dyad and also at the clinical care team, local team-based context, and applied it to a bigger community of practice, the HIV Psychiatry ECHO. I think many of you probably are familiar with the ECHO format. ECHO is an evidence-based distance education model that engages an expert hub and spokes, oftentimes community members who have less access to a specific expertise. And though most ECHOs target a clinical audience, our ECHO is unique in that we specifically wanted to target a non-clinical community worker audience. So most participants in our ECHO are community caseworkers or peer workers, though we do also open the ECHO to other clinical roles in the HIV sector. And our goal was to develop an integrative and to help community caseworkers develop integrative and mental health competencies to better serve people living with HIV. ECHO in general emphasizes a brief didactic learning, typically about a 20-minute didactic with a case-based discussion. And we've been really lucky with our ECHO HIV Psychiatry. The Ontario HIV Treatment Network has absorbed the ECHO after our initial research demonstrating its efficacy. And the OHTN now offers the ECHO twice annually as part of its regular education programming across Ontario. This is our hub team. A shout out to many people from our department, Tim Guimond, Elise Hall, Alan Way, who have been so essential to this work and moving it forward. You can also see that there is significant expertise from community. Stacey Adepoku, Celeste Bilbao Joseph, and Dawn Scarlett bring decades of experience as community workers in the HIV sector, working at different AIDS service organizations over the years. Thomas Egdorf from Casey House is an educator in the community, and Trevor Hart is a researcher in HIV at TMU and a psychologist by training, and our amazing peer educator team, Tara Jewell, Stas Tikhonov, and Dean Valentine, have been involved in this work from the beginning at its outset. And I've included our operations team here as well, Diana and Tanya from the OHTN, who really help the whole operation move smoothly. And here I'll show some of what we've learned from studying the ECHO and looking at what happens over the years as we've implemented these learning mechanisms for adaptive expertise in a community of practice. The ECHO really did start out as a community of practice. We all had a shared interest. We wanted to share best practices by experts, and we wanted to engage in knowledge sharing and a shared understanding. We saw that as we invited uncertainty, engaged in perspective exchange, and tried to facilitate integration, we started to see qualities of a knowledge-building community emerge, that this was a group that wanted to engage in collective inquiry together, that they were interested in generating questions, and that they were interested in adapting and improving existing knowledge toward new solutions for their clients and patients. This concept of improvable ideas is really core to knowledge building communities. And we saw this in action in the ECHO as we created these spaces for learning. And then another idea that's really core to knowledge building communities is idea diversity, that diverse kinds of knowledge are equally valued. And when we engaged in perspective exchange, not simply task sharing, and created the psychological safety for risk-taking, we really saw this idea diversity, that different people in the ECHO, peers, community workers, clinical community workers, clinical hospital-based workers, saw cases from a different angle and were able to integrate their different perspectives towards a new solution. And as this happened, we also saw evidence of collective responsibility. This enthusiastic collective responsibility that we are better together, that doing this work actually felt better together, that for many of the individual healthcare workers, they had felt disempowered doing this work in a silo, that navigating patient complexity on your own can be quite disheartening. And so finding a community of practice that had this knowledge building potential could actually help improve self-efficacy. So here you'll see all the learning mechanisms that we've already talked about. I won't go through them again. The only thing I will say is that, as I mentioned, when we have a stance of epistemic humility, we invite uncertainty. And as I mentioned before, because of traditional power hierarchies, it is important for those with traditional power, like the MD in a group, to model this behavior, to invite uncertainty. It creates these psychologically safe spaces for risk-taking. And in a group like the HIV Psychiatry ECHO, the idea diversity is huge. And what people can do with that is really incredible. I think it's helped me understand why knowledge-building communities are proposed as a way to tackle complexity in the healthcare system and why they do have so much potential. There are challenges and limitations of this work, which I'll share with you. I think education can be an overlooked part of QI or models of care work, and we would argue that it's an important partner, that there is, of course, a need for systemic healthcare change and solutions, that education is not the only, it cannot be the only solution, and that, as with all things that are worthwhile, time is a scarce resource. And so important for us to think about how do we help convince folks in the HIV sector and beyond that this kind of time commitment is worth it. I think that experts often recognize that time for engaging in perspective exchange really does pay forward, and we all lead very busy lives, and so this is always a challenge. And then finally, how do we demonstrate impact? When we did studies at the individual teacher-learner dyad and also at the team-based level, we did have some patient care study. And at the ECHO, it becomes more challenging. We are reliant on healthcare worker report of how their practice has changed. And so something we're thinking about is how do we demonstrate patient-level impact of that work? I'll leave you with these conclusions. I know that we went through a lot today. I hope that you'll leave here knowing that the purpose of education is to develop future experts and that we can't leave this up to chance. That there are learning mechanisms in psychiatry that support expert work. Those include epistemic humility, being able to invite uncertainty, that inviting uncertainty almost inevitably leads to perspective exchange as long as it's the first step, not the last, and that this kind of perspective exchange leads to integration of diverse kinds of knowledge towards collaborative reformulation, that we can cultivate these learning mechanisms at individual teaching dyads or team-based environments, as well as in larger community of practices, towards becoming knowledge-building communities, and that KBCs hold some interesting potential for solving complex problems in healthcare. There are a lot of people to thank for this work. I mentioned Maria Myalopoulos, who is my research mentor and collaborator in this work, Sandalia Genus as well, who was the research coordinator on many of these projects. I want to thank the hub members, Tim, Elise, Alan, Celeste, Stacy, Dawn, Trevor, Dean, Tara, and Stas, as well as Belinda, who we've recently welcomed onto our team as a new research coordinator on our work. The OHTN has been incredibly generous in supporting this research and the educational initiatives through an Endgame Award and other education grants. I'm incredibly grateful to the Sinai Health team, Leslie Weisenfeld, Tammy Beth Kuchar, Bob Maunder, and all of the psychiatrists and clinicians in the Clinic for HIV-related Concerns at Sinai. And thank you to the department for support of this work through an ASA. And to the residency program, I'm very lucky to work with such talented educators, Adrienne Tanner, program director, our assistant PDs, Petal and Inbal, and also Sanjeev Sakalingam, our vice chair of education. Thank you, everybody. I have references. I'm happy to share my slides if they're of interest to you, and I'll stop sharing for any questions.
Deanna, thank you. This was Dr. Chaukos. This was an amazing presentation, really thought-provoking for a lot of us who do some of this educational work and even clinical work. How you spoke about integrating that not only to learners but to clinicians and physicians, and a lot of it with clinical work is particularly in psychiatry. It's very team-based, and to have that framework that you explained and to think about at because learners at every level, even when we're early career, mid career, late career. So, as you said, if you're open to it, the possibility is endless. And I think I really love the way how you framed it, that openness and exchange allows people to feel more comfortable with that whole aspect about psychological safety and providing the environment and going through. So thank you for that. It really made me, and I'm sure a lot of the people on online as well, reflect and think more of how we work with all the other clinicians in the team. I had some questions, and maybe I'll ask others to put it in the chat as well. Normally we have a Q&A section of the chat. This time we don't, so people feel free to just put it on the regular chat, and we will try to get to some of them or most of them in this session, or when we will. Otherwise, we can always reach out to Dr. Chaukos to answer some questions if needed. Thinking about, I know this study, maybe you can correct me, but it was more focused on psychiatry and HIV and at least the clinical work. How does these perspectives relate to other fields like psychiatry versus surgery versus medicine? Is there a difference, or I would love to hear your thoughts on that.
Thank you so much, Raj, and thank you so much for your kind words as well and reflections. I love this question, and it's something that we talk about in our research group. I didn't describe all of the studies that support these learning mechanisms, but the data that I presented to you, or the take-home messages that I presented, draw on studies of residents and teachers, also clinical teams that involve different kinds of roles, community roles, also hospital-based allied health roles, social workers, and then of course psychiatrists. And then the ECHO is really diverse kinds of roles, so that's a different context altogether. I think part of why we did this work is because we know that some of these learning mechanisms are important for expert work in medicine, but we don't necessarily have studies in psychiatry for how it applies to us. So I think this gives us a framework for thinking about how does something like integration manifest in psychiatry. We know that as psychiatrists, it's probably especially important for us to integrate with other community roles that are working with clients on their mental health issues. I think it does transcend to other contexts of care, especially when complexity is a factor, because as a CL psychiatrist, I work mostly amongst internists, and I think I see this on a day-to-day basis on the CL service. I was just talking to a resident before this rounds about how do we navigate ambiguity in the CL setting with all of the different other physicians at play. So I think that there are other studies in different contexts. Actually, some of the papers I cited come from surgeons. Carolyn Moulton is a surgeon, at U of T, and some of her work speaks to the importance of interconnectedness and how we see these problems. So similar and also different.
Thank you. By the way, the Q&A is up, so it's just to let the audience know, so you can put in the Q&A. So there was a good question here about do you think the success of this approach requires an explicit agreement and understanding among participants? What are your thoughts on that?
That's a great question. Thanks, Rhonda. So I think that any learning dyad or any learning context really does require attention to the relationship and to the learning environment. So I think that's where making the implicit explicit does become really important. Welcome to your rotation in geriatric psychiatry. These are some of the learning objectives. I'm also curious, what do you want to learn on this rotation? Like, we do this as part of some of the standard work of teaching. And engagement, I think, is really a two-way street. I think that there is a way to recruit learners towards this kind of approach. Someone asked me recently about how I conceptualize productive struggle through a trauma-informed lens. Productive struggle is not traumatic. Productive struggle is uncomfortable. And I think when we think about the culture of medicine and some of the hidden curriculum piece, productive struggle can occur in a very supportive environment where we say, we expect you to fail in this rotation. You're not meant to know things you haven't learned yet. And so that might not feel like struggle, but of course, for any of us who know when we have a tough case and we don't know the answer, we're struggling enough on our own. We don't need someone to reinforce it. Maybe if someone makes it explicit and labels it, that's actually helpful.
Thank you. Yeah, that's very insightful. There's a question here about, they were posing a question about in psychiatric practice, how can clinicians effectively balance adherence to evidence-based guidelines with the flexibility and clinical judgment required for adaptive expertise?
Thank you. This is a great question. So, important differentiation for adaptive expertise. Experts apply an efficient solution to known problems. And part of the expert piece is knowing when something is a simple problem versus a more complex problem. And I think that this is where clinical judgment comes in and experience and making that experience expert experience. So I think an expert is able to differentiate, including when innovation is actually excessive. If you're seeing a patient and they have a first presentation of a major depressive episode, innovating in that context is probably counter to clinical care. And so I think that distinction is really about clinical judgment and helping learners to identify when is something actually actually a clear-cut problem in which you should adhere to guidelines versus actually us trying to fit a square peg into a round hole kind of situation.
Absolutely, absolutely. Here's another interesting question. They were asking about this approach, about the open dialogue approach. They were wondering if you were familiar and how this may have affected your work in any way. I mean, speaking of knowledge and knowledge failure and all. But anyway, go ahead.
Oh, thank you. Oh, I see the question. Thank you
Yeah.
so much, Shadden. I would love to hear more about the open dialogue approach. I don't know much about it. But I'd love to learn more about it. I think that one thing that is really important is that there's so many similar themes across. I look at this from an education lens. I think that there are very similar concepts in other fields of research. And in some ways we use our own language, but if we create shared language across some of these experiences, it actually allows for more synergy.
Yeah, absolutely. There's another very good question. I think you mentioned it a little bit in your presentation as well about impact evaluation challenges. I mean, this is not with this, but there's with so many CPAs and things that we do. And they were curious about your ideas of how you're going to target it, how are you going to, approach that?
Thank you. Thanks, Lou. That's a great question. It's interesting. Maria Myelopoulos and I talk about this a lot. We have caseworkers describe how their practice has changed since participating in the ECHO, and they have given very specific examples. And yet, when we submit these papers for publication, we do still get the feedback that someone describing change is not the same thing as measuring change. So it's an interesting conundrum. I think where expertise is actually about the individual healthcare worker, we do rely on self-report and how people gain insight into how they work. And I think that's actually really important because it has to do with professional identity, it has to do with sustainability in our careers, it has to do with how we work with other people. And if you have any ideas, Lou, for how we can measure impact sort of more broadly, these are vulnerable populations who are getting care from often many community organizations. And so I think the study would be a bigger and much more vulnerable making study. So it's one that we're still thinking on.
Thank you. There's a question about, obviously you have a lot of experience working with HIV and populations in the neurocognitive area, as a CL psychiatrist in so many ways. They wanted to know about your thoughts regarding adaptive expertise specific to working with cognitively impaired populations. It's on the other the chat.
Oh, thanks, Raj, and thanks, Omar, as well. So, Omar, I think I would ask you about that because expertise is a muscle that you flex, but we are experts in different realms. So, Omar is a neuropsychiatrist and geriatric psychiatrist at Bridgepoint. I think we learn from each other and different expertise. So, I think if I wanted to better understand adaptive expert work in this realm, I think I would look to people working in this realm and think about how do you integrate integration? What are the different perspectives that are essential for adaptive expert work in, a TBI population? And though I think it would be subtly different in different aspects of psychiatry, I think that there's probably a lot of similarities across areas as well.
Absolutely. There's another question by Glendon Tate, one of our educational leaders. He's asking a very interesting question about, how do you counter the hidden curriculum in teaching? How that sort of counters, absolutely right, counters that, at least in the past, expertise, and how do we continue with education, faculty development, to help our teachers that have learned the traditional approach to kind of embrace, this sort of, which, the approach that is really that, we need to move towards. So
Thanks, Raj, and thanks, Glendon. Can I say the same thing that I would ask Glendon this question?
yeah.
I think I think about this a lot. I think that it gets at this piece of how do we make the implicit explicit? How do we think about what are the threats to creating psychological safety for risk taking? Knowing that we need our learners to take risks, we need them to struggle, we need them to fail, and to be able to unpack that. Not gracefully in the moment. None of us, when we fail, do it smoothly in the moment. When we step in it, we're in the hole, right? And how do we help put words to that so that they can see that we all have been there? We will go there again, and that it's our professional accountability to engage in that and to bring other people in so that we can learn from other perspectives. That's, I think, how we counter that hidden curriculum piece that we should somehow know the answer. I don't think that we can expect individuals to know the answer every time.
No, thank you. There's a really good question here as well about curious if you had any info on learning satisfaction and other learning performance outcome with this approach.
Thank you, and thanks, Tom. We we have a little bit of satisfaction data from the ECHO and also our subjective experience. We were running this ECHO over the past 2 years at a time when I would say online engagement and learning has been at an all-time low. And we had people show up week after week, put on their cameras, and really give it their all. We recently welcomed a new research coordinator to our team, Belinda, and she came to some of our preliminary meetings, Belinda Chang, and she said, wow, it's a very opinionated group. And it is, and that's what's awesome about it. In that I think like when you create spaces where people can actually share what's on their mind and not be worried about judgment, but be open to feedback and to be engaged on that, it's invigorating. I think we all are looking for that.
I'm going to, I think Frank, Dr. Summers may have his hand up, but Frank, if you could put your question in the chat, that is the way we're doing this session. So really appreciate it. Thanks, Frank. I'm going to go to Bob if he has any thoughts and questions about this, because I think me have worked with this project as well. But Bob, I'll open up to you.
Thanks. I did a little role in this project, but I've got a question that goes right back to the beginning of your talk, Deanna. Because I was struck when you said when you referred to the experts in the audience today, that there's lots of experts who are joining in today, and yet you wouldn't necessarily expect them to be able to explain their expertise, right? And in fact, many of those experts would have trained and had developed a lot of experience before the concept of adaptive expertise had even been formulated. Reminded me of, in the same way that we wouldn't necessarily think that an artist is the person who's best placed to explain their art. They just do what they do. So then as you describe the kind of really pragmatic ways that the how of how we can help learners to share perspectives and to invite uncertainty and integrate knowledge, kind of all the building blocks of the adaptive expertise that they're going to develop. It made me wonder if you think it's helpful for them to also understand the concepts of adaptive expertise and of productive struggle. Like, do they need to know, is it helpful to know what you're doing, or is it sufficient to just be able to do it?
Thanks, Bob. So it's a fun question to think about. So I think one is that adaptive expertise is not an ideal. It's not like what we're trying to do, it's what we know experts do. So even before it was described as a concept, experts were doing this. And now there's this field to describe what experts do to make it explicit. So I think whether or not we describe to students the theory behind adaptive expertise, when they become experts, when they flex that muscle and hopefully become experts, they will function in these ways. And I think it is an open question about whether teaching students about these mechanisms is what's needed to do it. I think if we make the way for learning to happen explicit, we don't necessarily need to have a lecture on adaptive expertise, though of course I've tried, and Adrian has been good enough to indulge me in this. We do have adaptive expert content in the residency program curriculum in different ways. And at the same time, I think when you're learning on the ground in the clinical context is probably when the sort of learning from productive struggle happens, and making it explicit in that context with the teacher is probably the most potent, as opposed to the theory in classroom.
Thanks, Bob. There was maybe I just want to be respectful of Frank. I know one last question before we end. There's an interesting question about how do we get community workers to change their feelings? I think in there maybe there may be some historical, dynamic things and challenges with psychiatrists. So any thoughts on that question?
Thanks, Frank. It's a really important question. I think um, I would say epistemic humility. I think that we have to own psychiatry's history and also create spaces where we can engage like we did in the ECHO. But like many people in the audience do in their day-to-day work, whether it's on an ACT team, whether it's being embedded in a community-based site, whether it's doing collaborative care, I think that the way that we change this is by engaging in perspective exchange and collaborative reformulation, where we integrate the community expertise into how we see patients. One of our residents sent me a paper this week on the patient perspective and how when the patient perspective is left out of care, that there is this epistemic certainty in how we approach psychiatry. And I think epistemic humility is maybe the opposite of that. So I think inviting that idea diversity is how I would guess to do that.
Thanks, Dr. Chaukos. And this is a wonderful talk and very enlightening conversation and thoughts, and I think makes us all reflect again. So thank you for making the time to present today. Thank you, everyone, for joining. And hopefully you'll have a good weekend, and we will see you next month in Citywide Psychiatric Grand Rounds. So take care, everyone. Bye.
Thank you so much, Raj. Thank you.
Thanks, Bob.